Good morning. Today we'll learn about diabetes mellitus. First, let's go through the definition of diabetes mellitus. It is a group of syndromes associated with hyperglycemia, altered lipid metabolism, and increased risk of complications due to vascular diseases. So basically, it is a problem with the glucose metabolism which leads on to all this. So let's try to understand a little bit more about diabetes mellitus. The causes of diabetes mellitus could be because of a decreased insulin secretion, or could be because of insulin action, or both. We'll try to understand a little bit more about this, what it means. So let's go through the next part. Types of diabetes. Diabetes is classified into 4 types: type 1, type 2, type 3 and type 4. Type 1, previously known as IDDM, diabetes, insulin dependent diabetes mellitus. Type 2, non-insulin dependent diabetes mellitus, are also called as adult onset diabetes. There are other types, secondary diabetes, and the fourth one is gestational diabetes, also called as GDM. Type 2 is the most commonest type. So before we understand about types of diabetes, we need to understand what is a hormone which is lacking in diabetes. All of us know it's insulin. Where is it secreted from? Pancreas. Once it's secreted from pancreas, where does it act? It acts on almost every tissue, predominantly the peripheral tissues like muscle, liver and fat cells. So insulin is secreted from the pancreas, and insulin acts on muscles, liver and fat cells. So where are insulin receptors present? Insulin receptors are present on muscle, fat and liver cells. Type 1 diabetes mellitus. Here the pancreas are destroyed, so beta cell destruction occurs. Because of this, there is no insulin production. This has a rapid onset and usually occurs in childhood. Reasons could be autoimmune or idiopathic. What is type 2? Here predominantly the receptor is abnormal, whereas there is insulin receptor present, muscle, fat and liver tissues. Here the receptor is abnormal. What predisposes to this abnormality? Overeating, obesity, underactivity, aging could be the predominant risk factors associated with type 2 diabetes. Is it only that the receptor is abnormal? No, it could also include insulin deficiency. So type 2 diabetes includes insulin deficiency as well as insulin resistance, a receptor defect. This is influenced by the environmental factors seen in adults, runs in families. Type 4 diabetes mellitus is gestational diabetes mellitus. That is, a normal lady becomes pregnant and during pregnancy she develops diabetes. Who was non-diabetic becomes a diabetic. This is called as gestational diabetes mellitus. So after delivery, it might not, the blood sugar levels might become normal, might not also become normal. What is the importance of this gestational diabetes? The risk of perinatal morbidity and mortality is very high. So how do we diagnose diabetes mellitus? What is the diagnostic criteria? Normal blood glucose levels. For that we have fasting blood sugar levels, 2-hour postprandial or PPBS, HbA1c. Sometimes RBS also is included. Let's try to look into the normal levels. Fasting less than 100, normal, and postprandial should be less than 140. HbA1c less than 5.6. If it is above 126, it is called diabetes. If it is above 126, it is called diabetes mellitus. Fasting above 126. Postprandial above 200 is called diabetes. HbA1c above 6.5 is diabetes. Then what is between 100 to 125? This is called pre-diabetes. If fasting blood sugar levels are between 100 to 125, it is pre-diabetic. Fasting is between 140 to 199, it is pre-diabetic. HbA1c between 5.7 to 6.4, it is pre-diabetic. Coming to the simple thing, what is HbA1c? HbA1c is glycosylated hemoglobin. High levels of glucose in the blood are going to glycosylate hemoglobin, which can be measured, which is called as HbA1c. What is the significance of HbA1c? HbA1c shows an average 2 to 2.5 months of blood glucose levels, average of 2 to 2.5 months of blood glucose levels. If we consider RBS into this, if we consider RBS, random blood sugar, any point of time, if the blood sugar levels are more than 200 milligrams, then with signs and classical signs and symptoms of diabetes, then the patient can be considered as a diabetic. So, what are our diagnostic criteria? Fasting blood sugars, postprandial blood sugars, HbA1c, and random blood sugars. In this, we understood diabetes, fully fledged, full blown up disease could be diabetes mellitus, or there is also called as pre-diabetes. What is pre-diabetes? If we are able to control the blood sugar levels, then he might revert back to normal. A full-blown diabetes will never revert back to normal. So, he is going to be a diabetic for lifelong. What is the pathophysiology? Pathophysiology, the reasons why a person develops type 2 diabetes. There could be insulin resistance, that is receptor abnormality or impaired islet function, that is decreased insulin secretion. There could be n number of causes like the post-receptor defects, insulin receptor kinase activity decreased insulin receptor numbers, etc. What are the clinical manifestations or the clinical signs and symptoms of diabetes mellitus? There could be polyuria, increased urination, polydipsia, polyphagia, and dry mouth. What are the other symptoms which could be associated in diabetes mellitus? They could have delayed wound healing, tiredness, fatigue, irritability, sudden loss of weight, blurring of vision, headache, genital candidiasis, impotence, generalized itching, tingling and numbness in the lower limbs that symbolizes neuropathy, repeated skin infections. What are the risk factors associated with type 2 diabetes? Family history, it runs in the family. Obesity, BMI more than 25 kgs per meter square. Inactivity, ethnicity and race, that is Indians are more prone, African Americans are more prone. If previously the patient is identified to have impaired glucose tolerance or the patient is having pre-diabetes. The mother who has delivered a child infant above 3 to 4 kgs means the mother has GDM, gestational diabetes, hypertension, prolonged hypertension, HDL cholesterol less than 35, triglyceride levels more than 250, polycystic ovarian diseases, and history of vascular diseases. Why is it important that we treat diabetes mellitus? Diabetes mellitus has to be treated because it can cause complications. One, acute complications like diabetic ketoacidosis, HHS, that is hyperglycemic hyperosmolar coma, hypoglycemia, and lactic acidosis. It can also cause chronic complications like microvascular complications and macrovascular complications. Microvascular complications, namely eye diseases like retinopathy, macular edema, neuropathy, that is sensory autonomic nephropathy. So, macrovascular, coronary artery diseases, peripheral arterial diseases, and cerebrovascular diseases. What does this mean? Diabetes is not just about increased blood sugar levels, it is about the consequences of having diabetes. Diabetes can cause, in acute conditions, it can cause diabetic ketoacidosis, HHS. Chronically, it can cause increased risk of stroke, coronary artery diseases, MI, peripheral vascular diseases, nephropathies, retinopathies, and neuropathies. That is why it is important that we treat diabetes mellitus. There could be other diseases also which can be involved like urinary conditions, gastrointestinal conditions, autonomic nervous system could be affected. There are more than 100 skin diseases, skin diseases which is associated with diabetes mellitus. Increased risk of cataract, glaucoma, periodontal diseases, and musculoskeletal diseases are associated with diabetes mellitus. So how is increased blood sugar levels able to cause all these complications? Increased blood sugar concentrations or increased blood sugar glucose levels are going to increase the formation of sorbitol by the aldol reductase pathway. This sorbitol or glucitol is going to damage the tissues. This is going to damage the tissues. Hence it will be especially endothelium, and it is able to bring out vascular changes. That is why we need to treat diabetes mellitus. So how do we manage diabetes mellitus? Diabetes mellitus, all of us know, it is increased blood sugar levels. So how do we manage? First, we need to decrease the other reasons or the other factors, risk factors associated with it. So we are going to be dealing with lifestyle management. Diabetes self-education has to be taught. Patient itself has to be taught how to handle diabetes, like taking medication, how to improve his exercise, diet, eating habits, stress management. And along with that, there is going to be medications. Medications are of two categories. One is oral anti-diabetic drugs and insulins. So we learned that diabetes management is not only about drugs, it also includes lifestyle management, education of the patient, diet, guidelines, exercise, and drugs. What are the lifestyle management? Why with lifestyle management, how is diabetes going to improve? Exercise. If the patient is able to exercise, the need for insulin reduces. If the patient is able to decrease the calorie intake and decrease high glycemic index foods, increase fiber content, the insulin needed or the number of drugs needed also are going to be reduced. Weight reduction increases insulin sensitivity. Weight reduction. So weight reduction is plays a very important role in the management of diabetes mellitus. So coming back to our drugs, in pharmacology we'll learn more about drugs. So what are the available treatments for treatment of diabetes? We have insulin and we have oral hypoglycemic drugs. Insulin, we know type 1 diabetes is predominantly insulin dependent, or there is no insulin secretion, so we need to give back the insulin, that is replacement. So insulin is the main line of treatment. Other than that, we have oral hypoglycemics, which are the main line of treatment in type 2 diabetes mellitus. So these are few drugs which are used in diabetes, the oral hypoglycemic drugs. Like we have sulfonylureas, meglitinides, GLP-1 analogs, DPP-4 inhibitors, biguanides, glitazones, alpha-glucosidase inhibitors, SGLT2 inhibitors, amylin analogs, D2 agonists, and glitazards. First, let's learn about insulin. What is insulin? Insulin is secreted from the beta pancreatic cells of pancreas. So, what is the role of insulin? Now, in this picture, you see a kid in December 15, 1922, who developed type 1 diabetes, who is thin and weak and fragile. He was started on insulin on that day, December 15th. 2 months later, he is chubbier, healthier. So, insulin is an anabolic hormone which is going to help him to build the fat residues, proteins, and carbohydrate residues. So, remember the pic, we'll come back to it. So, first let's try to understand how is insulin synthesized. Insulin is synthesized as prepo-insulin, which is broken down to proinsulin, which is further broken down to insulin and C-peptide. What is the C-peptide? Insulin has two chains, A chain and the B chain. A chain and B chain. These two are connected by the C chain, that is the connecting peptide or the C-peptide. This is broken down. The whole thing is proinsulin. This is broken down to insulin plus C-peptide. For every one molecule of insulin secreted, one molecule of C-peptide is secreted. These are the amino acids. There are 51 amino acids in the insulin molecule. 21 plus 30 amino acids. So, C-peptide is used to find out the amount of insulin secreted in the body. How is insulin secreted? When food is eaten, the glucose enters into the beta cells of the pancreas. They undergo they undergo glycolysis in the TCA cycle to produce ATP. This ATP blocks the ATP sensitive potassium channel. Once these are closed, the cell will undergo partial depolarization. This is in the beta cells of pancreas. It will undergo partial depolarization and opening up of the calcium channel happens. This calcium channel is going to cause depolarization, which is going to result in insulin secretion. So let's look into the same thing in a picture. Glucose enters into the glucose in the blood. When you eat food, the glucose enters into the blood. The glucose undergoes glycolysis to produce ATP. ATP is going to block potassium channel, which is going to cause depolarization, which is going to cause release of calcium. This calcium is going to trigger release of insulin. This is what happens in beta pancreatic cell. So this is how insulin is secreted. So what are the factors which are going to modify insulin release? The factors which are going to modify insulin release, those which increase insulin secretion: glucose, free fatty acids, amino acids, GIT hormones like gastrin, cholecystokinin, secretin, glucagon, growth hormone, cortisol, acetylcholine, beta adrenergic stimulation, adrenaline, sulfonyl ureas. Sulfonyl ureas are oral hypoglycemic drugs. The drugs which or the factors which are going to decrease insulin secretion: decrease blood glucose levels, fasting, stomatostatin, alpha adrenergic activity, and leptin. So we understood insulin is secreted by the beta pancreatic cell. Where do these act? They act on insulin receptors. Where are insulin receptors present? They are present in the liver, fat cells, and in the skeletal muscles. What kind of a receptor is insulin receptor? Insulin receptor is a tyrosine kinase. Insulin receptor is a tyrosine kinase receptor. It has two subunits, an alpha subunit and a beta subunit. To the alpha subunit, insulin is going to bind. This is a beta subunit. Once this binds, there are going to be phosphorylation of several substrate proteins, which is going to either stimulate or inhibit the enzymes. So we'll look into how does this happen. When insulin binds, there is going to be activation, which can cause phosphorylation of several substrates, which can cause translocation of the GLUT transporter, that is GLUT4 transporter, to the periphery. Because of this, there will be entry of glucose into the cell. Because of this, the entry of glucose into the cell. Where is this insulin receptor present? Insulin receptor is present in the skeletal muscles, liver, and adipose tissue. Once insulin binds, glucose will be able to enter into the cell. Once glucose enters into the cell, the blood glucose levels is going to decrease. So it will cause decreased blood glucose levels in the blood. So this is one of the activity. Other than that, insulin can also increase the expression of GLUT expression, more synthesis of GLUT transporters. What is GLUT? GLUT is a glucose transporter. There are 7 kinds. One of them, GLUT2 is present in the pancreas. GLUT4 is present in the skeletal muscle, liver, and fat tissues. It's present in the liver and fat tissues. Not only that, it can also cause autophosphorylation and cause increased glycogen synthesis, and it can also inhibits phosphorylase. It also increases glycogen deposition. Let's look into what are the actions of insulin. Insulin is going to increase glucose transport. It is also going to increase glucose utilization. It is going to increase glycogen synthesis and going to inhibit phosphorylase, that is glycogenolysis, breakdown of glycogen, and also inhibits gluconeogenesis. What do we understand by all this? We saw the kid where the kid had become chubbier, means the glucose in whatever the food was eaten, the glucose was converted and stored as glycogen. Breakdown of protein was not allowed, that is inhibition of gluconeogenesis. Fat accumulation was happening, that is lipogenesis, or in other terms we can tell as inhibition of lipolysis. So glucose was able to enter into the cells. It was being able to store as glycogen. Fat was being able to be synthesized, and protein metabolism was stopped. That's why the kid becomes chubbier. So it's going to inhibit lipolysis, decrease protein breakdown. So what is the role of insulin? Insulin is like a key which opens up the door so that the sugar or the glucose enters into the cell. So effects of insulin in the liver: it's going to stimulate glycogen synthesis, triglyceride synthesis, skeletal muscle glucose uptake, protein synthesis and glycogen synthesis. Adipose tissue promotes glucose uptake and triglyceride storage. So it is basically a anabolic hormone. Not only that, it can also inhibit certain catabolic processes like glycogenolysis, breakdown of glycogen, ketogenesis, gluconeogenesis, protein degradation and glycogenolysis in the muscle, and lipolysis. That is why the kid becomes chubbier. So what are the other effects of glucose? Glucose is other effects of insulin. Insulin can regulate glucose transport and metabolism. It can regulate lipid metabolism and also promote synthesis of glycogen and protein. How is insulin broken down? Insulin is broken down, which is endogenously produced in our body, is broken down predominantly in the liver, which is exogenously given from outside. If you take it, is predominantly broken down in the kidneys. Half-life 5 to 7 minutes. So where is insulin used? Insulin is used in type 1, type 2 diabetes, root, subcutaneous. It can also be given intravenous. Where do we use it intravenous? In diabetic ketoacidosis, HS, in a patient who is unable to take subcutaneous, like in ICU patients, severe patients. So with this we learned a little bit about insulins. We have started with the mechanism of action of insulins. How do insulin act? From where is it secreted? In the next class we'll learn about what are the types of insulin and how do we actually give, what are the parameters on which we are going to give insulin to patients. Thank you.